Chapter 19 discusses disorders of visual function. So there are a lot of different things that can cause alterations in vision. Some of them are disorders of the eyelids and optic globe itself, so things like conjunctiva, cornea, and uvea problems. We're not going to really focus on those too much. Other causes are things that would increase your intraocular pressure, specifically glaucoma, which we'll discuss. There are also disorders that can affect the lens in the eye, specifically cataracts. We'll discuss those as well. You can also get disorders of the vitreous humor or the fluid inside of the eye and disorders of the retina. And then there are also alterations that come from the visual pathways as well as the visual cortex, which we'll discuss, and alterations in extraocular muscle and eye movement. So we're going to start by talking about the control of the normal intraocular pressure within the eye. There is fluid inside your eye that we call the aqueous humor, and its job is to maintain the intraocular pressure within the eye. We need a certain level of pressure in there, and the aqueous humor and the movement of it through the eye is what we use to kind of maintain that pressure. That fluid also provides for the nutritive needs of the lens and the posterior cornea, so it helps to nourish those different eye structures. That fluid also mediates the exchange of respiratory gases within the eye. Aqueous humor contains low concentrations of protein and high concentrations of ascorbic acid, glucose, and amino acids, and it fills the anterior and posterior chambers of the eye. So as that aqueous humor flows, it has sort of a normal network that it travels through. Aqueous humor is produced by something called the ciliary body, which is in the posterior chambers of the eye. That fluid then passes through the pupillary opening and moves into what we call the anterior chamber of the eye. And then it moves to filter through something called the trabecular meshwork through the canal of Schlemm, where it returns to the venous circulation. So that's the normal flow of this fluid. So you can kind of see that here where the fluid normally flows kind of through from the posterior chambers, through the pupil to the anterior chambers, and then out that trabecular network. And so it should just kind of continuously be flowing through that space. In the pictures here, B is a picture that shows what we call open angle obstructed glaucoma. So there's an obstruction in that trabecular network that's blocking the flow. And C shows a picture of a closed angle obstruction where that normal kind of angle heading into the trabecular meshwork becomes occluded. So it's obstructed, usually caused by changes in the pupillary dilation. And we'll talk about both of those open angle and closed angle closures when we discuss glaucoma. So glaucoma is a disorder of the eye that can lead to blindness. It's actually the leading cause of irreversible blindness worldwide. The definition of glaucoma is an optic neuropathy, so changes to the optic nerve, characterized by something called optic disc cupping, which we'll look at, and visual field loss. Glaucoma is caused by an increase in intraocular or inside of the eye pressures that result from abnormalities in either the balance between aqueous humor production or its outflow from the eye. The most common cause is an interference with aqueous outflow from the anterior eye chamber rather than overproduction of the aqueous humor. So the vast majority of the time, it's not that we're producing too much fluid, it's that it can't flow out of the eye itself. There are different classifications of glaucoma. We have angle closure or narrow angle glaucoma versus open angle or wide angle glaucoma, which are the two types we're going to talk more about in depth. And these really depend on the location of the closure, how it affects the circulation of aqueous humor and or the resorption of that fluid. These conditions can be either congenital, meaning you're born with them, or they can be acquired. Most are acquired, and the incidence of that glaucoma, usually increases as people age. And there's also primary versus secondary glaucoma. So primary glaucoma means there's no evidence of any pre-existing ocular or systemic disease. The glaucoma has just occurred on its own with no secondary cause. And then in secondary glaucoma, that glaucoma results from inflammatory processes that affect the eye, or from tumors, or blood cells of trauma that produce hemorrhage in the eye that can lead to just an increase in intraocular pressure. So one of the things that we see maybe in someone with like a diabetic retinopathy, which we'll discuss, is that they get these changes to the small blood vessels on the back of the eye that can make them very kind of fragile and prone to bleeding. And that bleeding over time can increase intraocular pressure. And so that would be classified as like a secondary cause of glaucoma. So the first type of glaucoma we'll talk about is primary open-angle glaucoma. So this disorder causes an increase in intraocular pressure, and it's the result of an outflow obstruction of aqueous humor via the trabecular networks. It's often asymptomatic and chronic, and so as people's intraocular pressure is increasing, they are typically unaware of this. So this is something that we need to screen for in people to recognize if it's happening and treat, because if that intraocular pressure is allowed to persist over time, it can start to lead to blindness, because those increased pressures cause chronic damage to the optic nerve. And that can over time lead to visual field loss if that pressure is not treated. So open angle glaucoma is pictured here on the left. So you can see that there's that large kind of angle, and the aqueous humor is able to travel from the posterior chambers through the pupil into the anterior chambers, and it makes its way towards that trabecular meshwork. But within that meshwork itself, there's some sort of outflow obstruction that blocks the movement of that aqueous humor. And so it starts to build up and increase the pressures within the eye. The other picture is angle closure glaucoma, which we'll talk about on the next couple of slides. So etiology, diagnosis, and treatment of this condition. There are several risk factors that increase incidence of glaucoma. So things like age, again, as people's age increases, so does their risk. We see these more often in African American patients. There's also increased risk with family history. Those with hypertension and type 2 diabetes also develop more glaucoma. People with a history of migraine headaches as well as history of sleep apnea are at increased risk. So it's usually diagnosed through a procedure called tonometry, where we measure the pressures within the eye. We can also do ophthalmoscopic visualization of the optic nerve. So using an ophthalmoscope to look through the pupils at the back of the eye, we can visualize the optic nerve to get an overall sense of its health and to look for any changes that might indicate neurodegeneration caused by that increased pressure. And we can also do central visual field testing. So the visual field loss we usually see in glaucoma is a loss of peripheral visual fields first. So their peripheral vision is what starts to become impaired early on. Treatment for this is usually via topical pharmacological measures, so using eye drops. And we use eye drops that either reduce the production of aqueous humor or that help to increase the drainage of that fluid through the trabecular networks. In angle closure glaucoma, we have some sort of anatomic defect that causes a narrowing or closure of the anterior chamber angle due to the enlargement of the iris. So these are an acute attack is often precipitated by something like pupillary dilation, which is often caused by drugs. So someone takes a medication that causes their pupils to dilate, and that pupillary dilation changes the anatomy within the eye, and it forces that kind of angle towards the trabecular network to close. The signs and symptoms someone would experience is an acute ocular pain and blurred or what we call iridescent vision. Um, Also, when you look inside of this person's eye, you would probably see an enlarged or fixed and dilated pupil. Angle closure glaucoma is an ophthalmic emergency. So in the picture, you can kind of see this where we have on the left the normal angle, right, where that aqueous humor is flowing from posterior chamber through the pupil and into the anterior chamber and out. On the right is angle closure. And as the pupil dilates, it causes that iris um, uh, to enlarge, and that presses down or blocks that normal angle that the aqueous humor flows through. And that causes, again, this kind of acute increase in intraocular pressure. So most drugs contain warnings that tell people to avoid those in cases of acute angle closure glaucoma. The problem with that is many people are unaware that they're at risk for this until they would have an acute attack. So while those warnings are in place, people may not know to even heed them until they experience one of these acute attacks. So a little bit more about how glaucoma causes blindness. So this vision impairment usually results from degenerative changes in the retina and the optic nerve, and from corneal edema and opacification. So these increased intraocular pressures that are common in glaucoma cause progressive atrophy of the axons within the optic disc. So in the picture here on the left, you can see this is the retina, so the back of the eye. And kind of right here, this is a normal optic nerve head. Normally, we also have kind of this, what we call the optic cup. It's this sort of like kind of lighter yellow area near the optic nerve itself. This is the optic disc, okay? And so that's its kind of normal size on a healthy eye. As the glaucoma causes this progressive atrophy of those axons within the optic nerve, it causes the size and depth of that optic cup to increase. So this is what the back of the eye would look like in someone with progressive glaucoma. You can see that that cup is starting to really increase in sort of size and depth. Those changes that we see in the optic cup usually precede vision loss. So when someone is going in for regular ophthalmic exams, this is one of the things that eye doctor will be looking at is changes to that optic cup. Next, we're going to talk about cataracts. This is the most common cause of age-related visual loss in the world. So this is one that's, as people age, becomes very, very common. We find it in approximately 50% of people between the ages of 65 and 74, and in 70% of people over age 75. So again, cataracts are extremely common. And what happens in a cataract, the lens itself of the eye, which is kind of right here, is avascular, and it's usually transparent, and it has this biconvex body shape. The posterior side is more convex than the anterior side. But the big thing to understand here is that it should be transparent. Lens opacity that interferes with the transmission of light into the retina is what happens in a cataract. So that lens starts to become opaque, and then light does not transmit as readily through the lens and into the retina itself, this kind of back of the eye. There are a lot of different things that can cause cataracts, and the causes are really multifactorial. So things like effects of aging, there are also some genetic influences, there are a lot of metabolic and environmental influences, also things like drugs and injury to the eye can increase incidence of cataract formation. People who are diabetic are at higher risk. People who have a significant amount of long-term exposure to sunlight. So it's important to use UVA and UVB blocking um, items like sunglasses to prevent sun exposure to the eyes because of risk of cataract formation. Heavy smokers are also at higher risk. There are some developmental defects that can cause people to have higher risks or some trauma or diseases. So clinical manifestations, diagnosis, and treatment of cataracts. So usually what we see is visual acuity decreases for far and near objects. So both of them equally. Usually when we see visual acuity changes, it's either one or the other, but cataracts affects both equally. People also experience a lot of kind of glare of light or abnormal presence of light in the visual field. So people with cataracts often struggle like with night vision, and they also struggle with like driving at night because the glare from headlights coming at them is really pronounced. We diagnose cataracts through ophthalmoscopic examination to look at the degree of opacity within the cataract. And we also test for visual impairment on things like a Snellen chart. Surgery is the only treatment for correcting cataract vision loss. Surgery for cataracts is a relatively simple and very, very common procedure. It's an outpatient procedure. Patients come in the morning, they have their cataracts removed, and go home the same day with, outpatient instructions to use, different drops and things following surgery. But relatively routine surgery that happens on an outpatient basis right at an eye doctor's office. Then we'll talk about diabetic retinopathy. Diabetic retinopathy is the most common cause of blindness in the industrialized countries of the world, meaning that we see diabetic retinopathy commonly in the countries like the United States that experience high levels of diabetes. In non-industrialized countries, we don't see this because we also don't see the relative increase in rates of diabetes. The function of the retina normally is to receive visual images, partially analyze them, and then transmit those images to be modified within the brain themselves. So there are two types of diabetic retinopathy. There's non-proliferative or proliferative. Non-proliferative is really confined to the retina itself. We see this kind of overall engorgement or increase in blood supply within the retinal veins. We see thickening of the capillary endothelial basement membranes within the retina, and maybe development of these small capillary microaneurysms. We can also see a certain degree of macular edema, so edema kind of back here on the macula, and this can cause some degree of decreased vision. In proliferative diabetic retinopathy, this is characterized by formation of all these kind of new and fragile blood vessels all over the retina itself. This is a much more severe form of diabetic retinopathy. All of these new fragile blood vessels start to bleed very easily, and they can also form like kind of exudates and things. And these changes can threaten vision in two major ways. Because of that abnormal blood vessels and their tendency to bleed really easily, that blood can leak into the vitreous cavity within the eye and directly decrease visual acuity that way. And the second way it can damage vision is those blood vessels attach firmly to the retinal surface and also to the posterior surface of the vitrea. So normal movement of the vitreous may start to exert like a significant pull on the retina, and the retina can become detached, and this can cause progressive blindness. So retinal detachment is a significant risk of diabetic retinopathy because of the position of how those new blood vessels grow within the eye. So because of the risk of visual loss, it's essential for diabetic patients to have regular eye exams because the development of this is often asymptomatic until things like visual field loss or retinal detachment occur. It's good, and also, encouraging patients who are diabetic to maintain really good blood sugar control because that's essential to the prevention of diabetic retinopathy. A little bit more about retinal detachment. This is separation of the neurosensory retina from what we call the pigment epithelium. So you can kind of see that here where the retina itself is starting to pull away from the surfaces underneath. So that's what it looks like in the little cartoon, and this is what it would look like. You can see that retina kind of pulling away. This is what it would look like in ophthalmoscopic examination through the pupil of the eye. There are a couple different forms of retinal detachment. One is exudative, where we get this accumulation of fluid in the subretinal space that starts to push the retina away. We can also get traction causes, where there's scar tissue that forms that causes retinal detachment. And there's also something called regmatogenesis, and this is the most common type. And this is where the vitreous begins to kind of liquefy and collapse, and that causes the retina to detach itself. So when someone is experiencing retinal detachment, this is a painless condition. So someone will not experience any pain as this retinal detachment occurs. But they do get changes in their vision. And this can look like flashing lights or sparks in their visual field. It can look like small floaters or spots within their field of vision. And as the detachment progresses, the person might start to perceive like a shadow or a dark sort of curtain that's progressing across their visual field. Treatment really focuses on early detection and prevention of any further vitreous detachment and retinal tear formation. Then we're going to move on to the disorder of vision called macular degeneration. These are degenerative changes that occur in the central portion of the retina, which we call the macula, and this results primarily in the loss of central vision. So unlike something like glaucoma, which was primarily peripheral visual loss, this is really central visual loss. We have age-related macular degeneration. That's the kind of most common, and it comes in two separate forms. There's the dry form, where we have atrophy and degeneration of the outer retina itself. This is very slow progressing, and people are often, asymptomatic as it progresses, but it can change to the wet form. So it's really essential to monitor anyone diagnosed with dry form macular degeneration for changes to their central vision. So if someone is diagnosed with dry form, we might give them we often give them like a little kind of like visual field kind of card so they can test themselves for these changes at home. The wet form of macular degeneration is what we refer to as exudative. So we get all these little subretinal hemorrhaging that over time causes scar tissue formation in that area and the loss of visual function. So you can see that in the picture. This is an exudative form of macular degeneration. This is quite progressed, where we have all of this. This is all scar tissue on the back of the retina. So this person is probably experiencing a pretty significant visual field loss in that central vision due to all this scar tissue that's forming on the retina in that central area. So clinical manifestations, diagnosis, and treatment of macular degeneration. So again, the dry form is usually really slowly progressive and often asymptomatic, but it can progress to wet form. So it's important to monitor those patients for that progression, which usually takes the form of a loss of central vision. The wet form is characterized by fluid leakage that causes retinal scar tissue to form and the loss of central vision. Diagnosis is usually by ophthalmoscopic examination to look for those retinal changes that are characteristic on the back of the eye. There's really no treatment for the dry form, but we do know that things like smoking are a risk factor, so smoking cessation is essential. There are also some things that can maybe help prevent these changes in people at risk. So some certain dietary supplements like vitamins E, C, zinc, and beta carotene can be beneficial in these patients. Next, we're going to talk about visual defects. And a visual field is the area that is visible during fixation of vision in one direction. So if you hold your head steady and fix your eyes straight ahead, the visual field is everything that you can see in that kind of fixed state of vision. Okay. When we get visual field defects, we get kind of a loss of vision somewhere within that visual field. And it can manifest itself in a lot of different ways. And it can be caused by a lot of different things. It can be damage to the retina itself, like we saw in things like retinal diabetic neuropathies or in like a macular degeneration. It can also be caused by damage to the different optic pathways or to the visual cortex within the brain itself. One thing I want to point out on this picture is note how the fibers cross from the medial half of each retina through what we call the optic chasm. Okay, so there are different kind of visual field losses that occur because of this sort of crossing of those visual fields within the eyes itself. So like lesion 1, that's a lesion to the right optic nerve, produces unilateral blindness, so just on one side. Lesion 2, which would happen in the optic chiasm, may involve only those fibers that originate in the nasal half of each retina, and then they cross to the opposite side in the optic chiasm. So visual loss involves the temporal half of each field, so something called bitemporal hemianopia. Lesion 3 on that picture is a lesion to the right optic tract, and that will interrupt fibers and the vision that originates on the same side of both eyes. We call that homonymous, with loss of vision from half of each field. So we're going to talk about those a little bit more specifically. So with optic pathway disorders, the visual field defects that we see, or like the pattern in which people kind of lose their visual fields, of each eye or in both eyes together are really useful in trying to help like localize where the lesion is within those optic pathways. So again, remember that some of that information crosses at the optic chiasm and some doesn't. And so let's look at a couple of the different visual field deficits that we can have. So one is called anopia, or that's blindness in one eye. And in the picture, that's represented by number 1. So you can see that here, white is normal visual field retainment, and black is where we have visual field loss. And that corresponds to a lesion that's right here within the optic nerve itself, coming from the right eye. So all the signals coming from the right eye are completely lost. And so we get anopia, or blindness in the right eye. So we lose that right visual field. Okay. In hemianopia, we get loss of half of the visual field in one eye. I don't have anything here that really shows hemianopia. It would be kind of similar to what we see in number 1, except we would just lose kind of half of that visual field. Quadrotanopia is a quarter of the visual field loss. So again, just kind of one of those. We can also get heteronymous loss. That's loss of different half fields in the two eyes. Or homonymous hemianopia, that's loss of the same visual field in both eyes. So that might be something like what we see here. This would be we lost the left visual field in one eye and the right visual field in another. So that would be like a heteronymous loss. And that's a lesion probably right here in that optic chiasm. A homonymous loss would be like what you see in number 4. That's about a quarter of visual field loss, but that loss is in the same visual field in both eyes. And that's associated with maybe a lesion here in like the occipital visual cortex. So those are some of the terms that you should kind of be aware of and what that might translate to how someone sees. I don't need you to memorize kind of like all the little lesions that occur, but do understand like that largely this is caused by that crossover of visual fields, and know kind of the general terms and how they would describe those changes in visual fields. And then we'll discuss disorders of the visual cortex. So the visual cortex is the area of the brain specifically tasked with interpreting signals coming from the eyes. Okay. So visual loss in what we call the central or high acuity portion of the visual field, that's a problem located in the occipital pole. And this causes a loss of visual acuity and pattern discrimination. Um, so that would be kind of right here in this occipital pole. That's visual loss. So if there's damage to this area, the patient's clinical manifestations would be things like loss of visual acuity and inability to discriminate between like different patterns. We can also get cortical blindness. Cortical blindness is the bilateral loss of their entire primary visual cortex. And that person would be essentially functionally blind. We can also get damage to the visual association cortex. The visual association cortex is located kind of right here in front of that high acuity portion of the visual field. Damage to that area results in the loss of learned meaningfulness of visual imaging. We sometimes call that visual agnosia. The person with visual agnosia can see patterns of color, shapes, and movement, but they can no longer recognize them as being meaningful stimuli. So familiar objects can be described, but they won't be able to be translated to like be able to name them or to react to them meaningfully. So if you see common kind of things, you'll be able to describe it. Looking at a plant, I can tell, that it's green and it's got this certain shape, but I can't turn it into the meaning of saying, yeah, that's a plant. So that's what we call visual agnosia.